Right. Thank you, Iris Hunger. I'm daunted, flattered and daunted to be giving this presentation on behalf. So we were asked to give some reflections. Iris Hunger has already introduced us. We're basically a comparatively new department in the RKI, RKI being Germany's National Public Health Institute, focusing on international aspects. So we're already part of the story of the mobility of diseases and of pathogens and of people and its concomitant effect on public health. So I'll be offering some reflections. Iris Hunger has mentioned my dual affiliations. There are 4 slides here where that's relevant. 3 I draw on research predominantly undertaken at the London School. 1 I had on the template of LSHTM and I couldn't quite change it to Robert Koch, so you will see I've tried. So I reflect a bit on the different things you will see in a surprise move. The title of my talk has changed and I no longer talk about services, but public health institutes. At least that's where I hope to end up, with focusing on how RKI and the changes affect our positionality in this. And again, I'm sort of, you can also see that as a new department, we are very ambitious. So I said I would focus on people, pathogens, knowledge, and public health institutes. So let's see how far I get with all of this. Let me see. So one thing I wanted to point out at the beginning of the talk is that the very nice logo that the organizing committee has picked to show the world and the connections in the world. And if you look at a map, and not a particularly pretty map that I chose here, the world is largely divided into nation states. So while we see an increasing amount of this, the responses, and I think we're focusing more on the sort of public health interventions to some of the scientific phenomena that you describe, are predominantly implemented through a system that is housed at a nation state level. Perhaps one thing also to say at the beginning of the talk is that sort of the department that I had, and I'll come to that at the end of the talk, does less basic science and much more so we have this ongoing debate, is it implementation science or operational research, but much more sort of public health practice, a lot of capacity building or collaborative work, and then a lot of evaluations, implementation science and operational research alongside interventions. I tend to start my talks with lots of different questions. So I wrote down the questions around public health, for public health on mobility. I won't answer these questions in the talk, but I do think they're interesting. So how do mobile populations interact with the public health systems and service delivery? And how does this then affect health outcomes? How can we measure and understand the effects of mobility on people and on population health? In terms of the mobility of pathogens, and we did hear something about that, how do we understand and measure risk? So that's something that's big sort of area of operational research, I think, that we're undertaking here in the Institute. And how do we respond to this? How can we ensure better health and reduce those risks we identify? Which approaches are key? And then which governance arrangements and institutions are key in this? And that's, again, bringing it a bit back to National Public Health Institutes, I guess is the sort of simplistic answer there. But really sort of to give a flavor of the types of questions, I guess, guiding some of these reflections. And I'm going to start by focusing on the mobility of people and pathogens. And as Iris Hunger has said, I will draw on examples that were implemented by lots of different people in the department that I had. However, I wanted to start, and this is really just a tiny bit of work that I did predominantly before I arrived at the RKI 4 years ago, around mobility and health. So I led a group of researchers who in 2018 published a research agenda on migration, mobility and health in The Lancet around 5 issues. And sort of this was done together with the WHO. And we offered some reflections, some of which are more focused on health services, but I think they are relevant for the topic we'll be discussing today and tomorrow. The first observation from this group of researchers that we brought together a group of researchers from many different universities was that categories around mobility are used in a reductionist way. So we talk about asylum seekers, we talk about migrants, we talk about internal migrants. Each of these has has specific ramifications. We identified an urgent need to develop new methods to understand this mobility. So we heard about some of the challenges already in terms of identifying pathogen development in different parts of the world, around diphtheria in Africa, for example, but also how do we deal with largely mobile populations? How do we monitor their health over time if people are not captured in the national systems? And how does this mobility interact with health systems or health services and public health services, which again are very largely organized in a national way? There is a research agenda on health risks and benefits of mobility. I think we'll hear a bit about that tomorrow, about specific populations. And we said that you need a better understanding or governance mechanism to enable universal health coverage for mobile populations. So quite services focused. And I just wanted to briefly mention research I had undertaken with colleagues at the University of Cape Town, the University of Witwatersrand, York, and the Department of Health in South Africa, which actually continued until we finished at the end of 22. So we were a bit kicked out of the water by COVID. And we didn't look at the pathogen. We did a survey of people crossing land borders into and out of South Africa from neighboring countries. And a very large proportion of people cross. So these are very porous borders. They're land borders, as you will know, and many people cross in and out of South Africa 5 or more times a year. And we found that a very large proportion of these actually cross the border for medical purposes. So we did a study. I won't go into very great detail, but we focused on some health outcomes and tried to understand what's the impact on these particular outcomes, which was maternal and child health in primary healthcare settings of this greater mobility. And I just wanted to share really one summary finding that we identified as interesting. So that the type of mobility or why the causation, why people move or why they're mobile had an effect on how they used services, but it also had an effect on the health outcome. So we enrolled some mobile people into a cross-border survey and followed them over a period of 2 years. And we found that these legal categories, for example, that individuals had affected both the interaction they had with the health system, but it also affected the outcome they had on some of the conditions for which we had indicators. So treatment adherence around HIV, where the data is very strong in South Africa. Again, the PMTCT program in South Africa provides very strong data, and around immunization. So this was not linear, but it was interesting in seeing that the type of mobility affected the outcome for some of these indicators. And then confusingly, in some ways, but not confusingly, maybe to others who've done more research on this area, we also observed this sort of at population level, an improvement in health around mobility. So this healthy migrant effect, I think, has been described in quite a few populations. So I just wanted to give a sort of highlight around people moving and the effects on health outcomes. And then this is research undertaken here at the RKI by colleagues primarily in SIG2. So this is quite early. So we published this in 2021. So Richard has nicely outlined, as everybody was uploading these sequences onto NextStrain, obviously governments were taking actions, and they were taking actions including on the travel-related policies, having figured out these 10 million people that were in the sky. And so we, together with the Systematic Review Center at the American University in Beirut, undertook a systematic review in 2020. So it's for the time period of 2020, looking at travel-related policies during COVID-19. We identified 69 studies that were included and 3 main measures. These were border closures, quarantine, and screening. At that time, and the evidence base has changed significantly, we found that these were mainly modeling studies. So there were some observational studies included, some contextual studies, but mainly these were modeling studies. But we did identify some regional differences. So very clearly the 3 main travel measures taken: border closures, quarantine, and screening. But in terms of the regional differences, you can see here, Africa is at the top. In terms of, and you can see the timeline. So this is all just 2020 data, right? So total border closures, you can see differences over time. Here's Europe. And then partial border closures is in the orange, and the MENA region. And then you can see Australia, which this sort of kept this going for a relatively long time. So quite descriptive findings at this point. And then we looked at this in terms of possible outcomes, and our findings, and this is in a way now, I guess there's more sophisticated studies have been published since, but we found that border closures may reduce the number of cases and slow initial transmission, but really just initially. We also, and then I think about a year later, Mark Jitt and colleagues published this quite powerful study in The Lancet, which showed more with better data, really greater effect if implemented early and in combination with other measures. So we identified that at that point. We saw that quarantine in the studies we reviewed, there was a possible reduction of quarantine as a result, or a possible reduction in the number of cases, but this depended, there was huge contextual variation in the studies that we reviewed, and compliance and enforcement was reported in very different ways, and also was hugely important. And in the studies that we reviewed, it was shown to be more effective if followed by testing. So if people had to test out of quarantine. Screening was largely, in all the studies that we reviewed, largely unlikely to detect a large number of cases or delay an outbreak. And then at that point, there were only 4 contextual studies, right? So quite interesting. Also that time point in data now, there were 4, and they found concern about harmful impact. So they demonstrated some things around food imports, in particular focusing on Africa, at least 2 of the studies. Anyway, here's the reference of the paper, but just to give you a flavor. So obviously the people traveling with pathogens had a huge impact on, and the policies adopted, I think, had a huge impact. And the rapidly developing evidence base that we also heard around genomics and SARS-CoV was something that we grappled with. So then I'll onwards to mobility of knowledge. Iris Hunger already alluded to this also, that the sort of mobility as a theme of this symposium does not just refer to people and pathogens, but also ideas or knowledge, however you want to term it. And maybe you can detect the slide where I couldn't quite get the formatting right. So quite often in global health as a field, so if we say in our center we do global public health, quite often you have an intervention that looks like here. This picture means a health financing reform. Actually, I think it's from Ukraine. You have a new therapeutic or indeed a public health intervention, or you have public health advice. And what you do is you identify this, you test this in one setting, and then you take it to scale, right? So you scale up certain interventions. And I guess the paradigm that underlies this very much is one that has emerged over the last 30 years from evidence-based medicine, where really large data has been used to drive clinical practice, right? To make more, or the use of the scientific method to apply current data to improve healthcare decisions has been translated to global health, right? To global public health. And the epitome of that for many, and I say this with admiration, is IHME, right? And the global burden of disease. So it's about, and here's a paper that has been cited even more, but it's older than Richard. So it's been cited even more times by Chris Murray and Alan Lopez, setting out the original global burden of disease study, right? So they said, we do these things in global health, but we don't know the scale of the problem. We don't know what works. So we need evidence. Essentially, we need to quantify the problem, test the solution, and then apply it, right? So this is a little bit the paradigm that we operate under. And of course, it doesn't take a very big leap to see that in the practice of global health, in the very many different contexts in which we work as an international department and as an institute with many partners around the world, this can sometimes be a little bit challenging. So I just wanted to reflect on one project, or highlight one project that has taken that on in practice, that has been implemented by colleagues here in the institute. So there's now a sort of critical literature around global health policies and local realities. sociology, anthropology are some of the disciplines where this is where this has been reflected on, where you say, okay, global guidelines tend to be global if they apply to low and middle income settings. Guidelines and recommendations are often developed by international experts. There's a contested discourse around what constitutes expert knowledge, and then introduced in almost identical format across numerous countries with the aim to improve certain aspects of health systems. And these are, so one sociologist, the French sociologist Desjardins, has termed these as traveling models. So there is basically a critical analysis of these traveling models. I won't go into that so much, but what the response to that is, and what I think we try to live here in the Institute and also in the work that we do in the Center for International Health Protection, is really to co-produce knowledge. And I briefly wanted to introduce a project focusing on IPC in Nigeria in a healthcare setting, which applies this approach. So they've taken a participatory approach to learning, to co-develop an interaction around IPC practices in a teaching hospital in Abuja. And since 2019, so this is funded, we have a lot of projects funded through a program by our Ministry of Health called the Global Health Protection Program, which allows us to bilaterally collaborate with other national public health institutes around the world. And this is implemented with the colleagues in Nigeria CDC. And there, together with the colleagues in the nosocomial infection unit, we've trained 19 trainers and 92 healthcare workers from 23 hospitals in 4 of the regions and their medical directors. During COVID-19, actually, the project was able to pivot very nicely around COVID. And there were some nice success stories here, but I just wanted to show you some pictures here and some implementation practices. This is the University Teaching Hospital in Abuja. This is I guess in 2019, these pictures were taken where they had their hospital linen and the practices they used. And they assessed this, and they had an assessment score here where of a very low sort of assessment score that they self-administered. And then they went through this, they sort of together developed this intervention, trained health workers together, and changed the facilities, but they spoke to staff, and they together designed the interventions that they thought were needed for the quality improvement. And overall, now several years in, I think 4 years in of the project now, this has changed quite dramatically, the situation. So I hope you can see that on the pictures immediately. The facilities are different. They've got better equipment, but they have also their score has gone up here. You can see very nice, very happy after the training, and they've reflected on their practices and said that they worked as change agent. They listened to everybody. They co-designed this intervention. They developed a management structure that worked and sort of listened and continuously evaluated this. So this is one way of responding to, or in a different way, or implementing practice in a way that may speak to a more evolved distribution of knowledge. So still employing safe practices around IPC, still doing this capacity building, but really doing an integrated approach together. And here the PULSE team and the project team are obviously in the lead. And this is different departments in RKI who implement this with Nigeria CDC for a long time, and it's a very strong partnership. So then I wanted to end up a little bit talk and reflect explicitly on what this means. So I've touched very briefly on the role of pathogens and people, and also knowledge and ideas around public health, and the extent to which mobility has meant that we're really in a much more interconnected way. But I think always at the same time we have this reality that the structures and the governance through which we respond is really national. And what better place to start, one might say, than the National Public Health Institute of Germany, our own institute, the RKI. And indeed, the processes that I have just briefly touched on here have also, you can also see reflected in the history of just for our colleagues from Pasteur here in the history of our institute. So the Robert Koch Institute was obviously founded, just like the Pasteur Institute, for Robert Koch, already a famous scientist, right? And then we have gone through through a sometimes difficult history, and we reflect actively on our history. But I think part of what it means to be a public institution over such a long time also means that you are reflective of the wider societal context that go on. And why I've included this slide here is to show that in 2019, that's when the department that I now head and that the colleagues work in was founded. And this was a direct effect of the realization that international health protection is national health protection, as I think was the first talk already pointed out and was reiterated by Silva. And this realization in Germany came very concretely with the outbreak of Ebola virus disease in West Africa, where RKI colleagues actively supported. But also, and this is the German advice to, this is the advice to medical practitioners in Germany here on measures to take in case you have a suspected case, which again highlighted the close connection, right? So again, those people in the aeroplanes in the sky. So highlighted that, and then as a result, the German Infection Protection Act, our Infektionsschutzgesetz, which outlines the legal mandate of the RKI, was changed to explicitly extend the mandate of RKI to work with supranational bodies such as the WHO, but also foreign or bilaterally, scientifically in partner countries. And it's mentioned here explicitly for the colleagues who don't read German, the training and capacity building of personnel, support around epidemiology, risk, and crisis management, including, and I think that was a big step, the deployment of personnel of RKI abroad. So really reflective, our institution itself, National Public Health Institutes, had to change, I would argue, as a result of the mobility, as a result of mobility of knowledge, but also of pathogens and people. And we were not alone in this, and now I wish, of course, I had, because the colleagues from Public Santé Français are also close colleagues and they have similar, so I didn't include the slide, I apologize to the friends we had, but we were not alone in this development. So UK HSA, as it's now called, they have a global health unit, which we work very closely with. The Norwegian colleagues have, and of course, US CDC has a very big department on global health. So these very nationally focused agencies then engage internationally, and I'll be curious to hear about Ireland in the same vein. And there's also a great amount of networking that goes on. So there's the International Association of National Public Health Institutes, and that really provides vital collaboration on this. I wanted to briefly mention the structure of the center, being a bit unsure of the mixture of people in the room. Some colleagues are from the House, so apologies if this is very well known. Essentially, the center that is a matrix structure. So there's around, we have now grown to around 110 scientists or 110 staff who work only on this international aspects. But the whole house and the scientific expertise of the whole house is essentially potentially available for this. Of course, we have many other legal obligations. And we work closely with the WHO. So we have a GORN collaborating center. We have the National Focal Point for the Emergency Medical Teams Initiative. And we are a founding partner of the WHO hub here in Berlin on pandemic and epidemic intelligence. And we're very proud of that. So we work closely with them. We also host a secretariat, and again, it's the expertise of the whole house that we have here, but we have the secretariat for the German Biosecurity Program, which is a program funded by our Foreign Office, and some bilateral aspects. And then we do a lot of capacity building across 4 thematic units. So we have designated public health laboratory support. So we're currently working together with the WHO hub, for example, to help some countries articulate their policies around genomics and how to not just build the wet lab capacity, build some of the bioinformatics capacity, but also think through the public health applicability around what makes sense in my setting. So I've taken note of this diphtheria. Actually, I wrote it on my post-it, so I will ask the colleagues if this has come up in any. I mean, it's just 4 focus countries, but to give a flavor, whoops, sorry, I've gone back in the. I wanted the pointer. We have an epidemic intelligence where we monitor the events abroad. And then we have this evidence-based review function, which these are the colleagues, for example, who conducted the systematic review. So we review a lot of the literature. So just to give a sense of the international activity. So there's now, in reflection of this greater mobility, I think as a national public health institute, the RKI is really sort of, as together with many other of our brother and sister institutes, also sort of shows leadership internationally as a national actor, and very closely sort of the national response integrated with the international one. And I think it's really sort of a very nice, it's a nice and fascinating story of how these national institutions evolve in light of the greater mobility that we spoke about. And I just wanted to show a couple of more maps. Internationally, I always like showing maps, but it's just to say, so we started, obviously, I showed you it came after Ebola. We started recruiting, people were recruited in 2019. We really started just in time, maybe at the beginning of 2020. So the RKI provided COVID support to partner institutions in many countries in the world. Sorry, this is in German, but this was partly exchange of information, partly it was capacity building, a lot around the evolving sort of lab technologies, but also often just exchange and collaboration around information from which we obviously benefited just as much. But just that really underlines how important this international collaboration is, and the extent to which national work in public health now requires this in the face of mobility of all of the things. The mobility of ideas in responding to the threats is just as important. These are the projects we have at the moment. 2 different ways of looking at this. This is again of funded. I wanted to show you, there's one last map, one last slide I wanted to show to you. So these are projects, again, where we have longer bilateral collaboration, actually also with the Pasteur institutes in some of these places, although I was recently educated about the difference between the network and the institute. So you can see there is a lot of bilateral collaboration as well as the longer term collaboration with the WHO. And then I wanted to say that, of course, this reality means also mobility of staff, right? So there are these effects where, of course, in terms of our responses, in terms of the knowledge we need as an institute, the increased mobility has meant changes. But we also, I didn't really introduce that unit in the slide. We're also responsible to keep everyone from the RKI safe. And the colleagues kindly prepared these 2 slides, which I thought people would be interested in. So this is the mobility of RKI staff over the last 8 years. And you can see also COVID led to a suppression of activity, but you can see how much more mobile people have become as part of the sort of responding to this mobility. And I've got it broken down by countries, but you can see this is a lot. I mean, there will be multiple staff. We're about 1,500 in the institute, and obviously this will be people who travel frequently in a year, but still almost 700 journeys that are sort of logged here. And here you can see countries which have, so we divide countries up by the security risk, sort of the work they do. But you can see it's a fair amount of sort of high income travel, but it's also a fair amount of all around the world travel. So in many ways, or I would say in every way, sort of international mobility touches the practice of national public health institutes. And national public health institutes have to adopt and respond to this. Mobility of all has increased, of people, pathogens, and of ideas. And I think the systems we're standing up, there are many important initiatives, and science finds a way, NextTrain and GISAID, and they're the scientific products. I think the WHO hub is developing some of the sort of normative dimensions around this. The IPSN, for example, is trying to come up with standards around data sharing for genomics. But in terms of the global surveillance, there are certainly some aspects which which I think people, where we still have quite a long way to go. Public health systems and institutions retain a focus on the national and the nation state. And I think that's really important. Even the pandemic accord negotiations now, it's really interesting to see how the units that are really making the decisions are always at the national level. So national health is international health. And as such, I think national public health institutions are national and international actors. And of course, I was just the front person here. So this is I've just copied the email distribution list of my department, but it's really these people who I want to thank, who have undertaken most of the work, as well as everyone else on the RKI, but I haven't put everybody's email here. So thank you very much.
Thank you very much. The floor is open for questions. I mean, that was kind of like touching on a lot of topics, so I'm sure there are a lot of questions, please.
Thank you very much. So I really enjoyed your presentation, and thank you. You've sparked off a lot of thoughts in my mind, but there's just a few reflections that I provide to you just in immediate response, and I may pick up on some of these on my presentation tomorrow, so I'm giving a sneak preview. But one of the issues is around using the evidence base, which is great when we have a strong evidence base, but not so great when there is a weak evidence base. So as well as using the evidence base, I think we have to add building the evidence base. I know that's implied, but sometimes we need to be explicit, and particularly in under-researched areas of work, and that's very important in the inclusion health space. The second point is that we talk about pathogens, and of course we must. We talk about people, but we've certainly been advocating in Ireland and the UK a people not pathogen or people and pathogen approach. In other words, the concept that dealing with any infectious disease purely from the point of view of diagnostics, therapeutics, etc., is part of the problem, but it's not the whole problem. Thinking about the social determinants of health and the success or otherwise of continuity of care and all those things you mentioned is so fundamental to actually addressing the burden of disease, preventing transmission, and providing a better health outcome. So we need to shift some of the mindset in often the reflex response we have to categorize illnesses rather than think about people. So if we think about some people, they will have a higher risk of exposure to some infectious diseases, also homelessness, also incarceration, also substance use, and all of these things are mutually amplifying. And if we only tackle one element, we'll probably fail in addressing the public health achievements. So I just wanted to put that into this space, but really enjoyed your work, and thank you for the presentation.
Am I responding? Okay. Well, I couldn't agree more, right? I mean, so there, I already was ambitious in what I tried to cover. So, but I couldn't agree more. And I think, especially around this holistic public health, it's really hard to do that. And I think it's still hard to do that across, to have the continuity of care, to really think about that. I was saying to Sylvain I didn't include this slide. So actually we supported WHO in Cox's Bazar with a survey to help increase diphtheria vaccine uptake in the Rohingya refugee population, right? So it's, I mean, there's all these aspects, and there's so much around the mobile populations and their health records, for example, across borders, and then how that is perceived in our practice and so on. So completely couldn't agree more.
There's a question here.
Hello, Al Story. Thank you very much for a great talk. Your work's so inherently geopolitical. You're at the sharp end of a lot of debate. Where do you think in the years to come, let's say the short term, where do you think we could make most gain in generating evidence for equity?
That is a I don't have a blanket answer to that. I think that the public health systems, if you think around the measuring some of those challenges, has really been underfunded, right? So I think this not having the evidence base around a lot of these challenges is really something where we could probably make relatively quick gains that would then enable further action. But that's one of many, and it's maybe more tangible than saying you need to invest in housing and schooling and everything at the same time. But really difficult question.
Please, up there.
Thanks so much for the presentation. I really enjoyed it. And I was particularly excited when you started talking about the different statuses of people on the move, asylum seekers, internal migrants, labor migrants, undocumented migrants. And I do agree that for a big part of the discussion, it is a terminological debate, but at the same time, they also do come with different legal statuses and with legal rights. And this was where I got really excited because you mentioned that there is a need for new governance structures. And I'm curious if you already have something like, a highlight project in mind or an idea for a new governance structure that can go across the different migration statuses, but also perhaps beyond the different borders of the nation states.
So I think there was an attempt at that with the UN Compact. So I don't know if people know that IOM led a process that ended in 2020 in Morocco with a new compact, which was a sort of update on an international agreement around how cross-border migration should be regulated. And there was a health element in that. But so this is not RKI opinion, but my sense is that the compact has failed in achieving very much tangible impact. And I don't know where that work is going to go. Is somebody coming tomorrow to this discussion at the end or something? I think that's something that would be really interesting to reflect, because I think that was a moment where everybody had hoped such a governance would come, but it hasn't. And then, of course, for the pathogens, sorry to come back to that classification, there are quite strong things, right? So we have Nagoya, and they're like the most tangible things in international health that we have, are the agreements on how we exchange on samples, really. But we don't have anything at all approaching that on public health or people. I mean, even the IHR on any of that, it's completely not there. And I think in the beginning of that, when the process started, that was the hope, including by the WHO colleagues. That was the hope that they would put something in there. Yeah.
Okay, thank you. Are there more questions in the room?
Yeah, I liked particularly your part about the participation and the participatory approach, which is really, really needed and often not done. My question is whether already on a policy level, so when they start to develop guidelines, WHO, etc., there is already a participatory approach.
So I think they are different. I mean, there are probably people here who are involved. I mean, there's very rigorous, they have this process, right, for the WHO guideline. But I think that WHO, this process has become much better at including the community groups, no? Because for HIV, for example, you probably know the HIV process, right? The guideline process. They have a group, don't they, where they hear the community.
HIV has always been different.
Yeah. So I'm not sure it's the same to the same extent. I think there's a recognition that you need it. And I mean, and to be honest, credit to our ministry, I really mean this, credit to our Ministry of Health, right? So they fund this project, which is really super participatory. I mean, I think under a health protection funding thing, I think is pretty, I actually think that shows how far this has come. But of course, this takes lots of time, right? And quite a lot of money. So then there are like these trainers employed and they work and they work for quite a long time. On the other hand, of course, you can say if your intervention fails otherwise, then you have wasted the money, even if you had in the first year the questionnaire up. So it's about how you view this, but I think maybe halfway. We're still learning from HIV.
Yeah, and maybe to mention that in the new WHO, for those who might not know, in the new WHO preparedness and response planning, the community protection is a kind of like particular module or element, which already shows that there is a bit more, at least, focus now on the needs and the contextual factors and stuff. Let's see how that kind of like will work out in practice, but at least it's there as a term. Please.
Thank you. That was really interesting. Very different from what I'm doing, as you realized. It was very interesting for me to realize that the public health agencies go international, as you mentioned. And I'm kind of wondering about the funding of this new element for Robert Koch Institute, but also others, because I guess it involves a lot of engagement from the government, and there are probably political issues around it. So how is this dealt with in the long term to ensure the sustainability of the funding of this new branch of your institute?
So it was when they changed the legal mandate, it came with a funding increase, a permanent funding increase, but our department is much more heavily reliant on soft funding than the rest of the institute. So it's the factor is a bit reversed to how it is in the rest of the institute, but I think it was the political momentum of Ebola was used to create this, and it was now it's quite interesting to see. So some of the South Asian countries have approached us to advise and help them in the creation of their international departments. So I have supported some countries speaking in their parliamentary commissions, explaining what happened here, because now their CDCs also want an international department. So they are using COVID to